Hello, I'm Katherine West, Infection Control Consultant, bringing to you the next podcast addressing Let's Get It Straight. I know that all of you are really involved with response to COVID cases, and we thank you so much for the work that you are doing to service those in your community. I wanted to change to a different subject for today's podcast in keeping you up to date on the newest information on HIV. So let's go ahead and get started. Let's begin with epidemiology, the occurrence of diseases within a given population group. For 2019, there were about 37,000+ newly diagnosed cases of HIV infection. But because of the new treatment available for those that are infected, our AIDS cases have declined significantly. Let's get an update now on the occurrence of occupationally acquired HIV infection. And on September the 5th of 2019, the National Occupational Safety and Health, NIOSH, published updated risk data. And this is really exciting because our numbers have not changed from what was published in December of 2013. There have been no additional cases of occupationally acquired HIV. So going back to December of 2013, we were at 58 healthcare workers who had documented occupationally acquired HIV infection. Of the 58, 24 were nurses, 17 were lab staff. There were 0 cases in fire EMS and 0 cases in law enforcement. So this is really exciting news that these numbers have not changed. Remember that a documented case is one in which an exposure is reported, the source patient tests positive for HIV with viral load, the exposed employee's baseline is negative, and within the subsequent 4-month time frame, the healthcare worker converted to being positive for HIV. That would be a documented case. Now we do have another group called undocumented. These numbers also have not changed according to NIOSH in their report of 2019. So in the undocumented group, 150 healthcare workers were listed, of which 13 were fire EMS and no confirmed cases in law enforcement. So what does undocumented mean? It means that the individual cannot link it directly to an exposure on the job, but states that they have no risk factors in their life, and therefore the only way they could have become positive would have been related to the workplace setting. So where are we on risk data? The risk for acquiring HIV infection from a contaminated needle stick injury is listed at 0.23%. 0.23%. The risk for acquiring HIV from blood splatter to the eye is listed at 0.09%. And there has been one documented case of transmission related to non-intact skin that actually occurred in 1999 and was reported out in 2000. Let's go back to the type of needle stick injury that has led to a healthcare worker becoming HIV positive. The description would be a large gauge hollow bore needle that had been in the patient's vein or artery, and that the patient had a high amount of HIV virus circulating in their blood. So that is the type of exposure that has led to, in the past, a healthcare worker becoming HIV positive. So an update. In 2015, the CDC published that the risk for exposure due to splashes with body fluids is thought to be near zero, even if the fluids are overtly bloody. What about human bites? That, in particular, is a concern involving law enforcement personnel. But the good news is we have no documented cases of transmission through human bites for any of the blood-borne pathogen diseases. And we are conducting rapid HIV testing. This has been available since 1998. And in 2001, the CDC published that they wanted rapid testing done on the source patient if an exposure occurred, because we could get the results very quickly in less than an hour, and that would prevent an exposed healthcare worker from being placed on PEP drugs, antiretroviral drugs, as a precaution, simply waiting for blood work to return. That can be avoided by rapid testing. So we have several HIV rapid tests in the marketplace that involve simply finger stick. And of these listed HIV tests, OraQuick, Unigold, Clearview, ChemBio, and InSitu are waivered. What that means is they do not have to be tests that are performed by an approved clinical laboratory. So this makes these tests ideal for rural areas because blood work doesn't have to be sent out, and you don't have to wait for blood work reports to come back days later. We have very quickly, 10 to 20 minutes, a result that can be done in the emergency department at the bedside. Now, just recently, a new rapid HIV test was approved by the Food and Drug Administration. We have results in 1 minute, and the cost for this test is $8. A little bit of clarification. The CDC published very clearly that EMS personnel should not be involved in source patient testing, that this is clearly the responsibility of the medical facility. And HIV testing laws do not state that this can be done by any other than a medical facility. Also, the oral swab test is not acceptable for source patient testing. Blood testing is the only approved method, and that's because the level of antibody in oral fluid is so low that it may not be detected. Up to 1 in 12 infected people can test negative by using oral swab testing. So I think it's important to note that, once again, source patient is tested first, and that is to be performed by the medical facility using finger stick blood. Now, what about hospitals that may not be doing rapid testing? Well, number one, that would be an OSHA violation clearly in today's world. they are to be offering this even for their own employees. So originally, OSHA had stated that it's the responsibility of the employer to ensure that rapid HIV testing is performed on the source patient in an exposure situation. Well, the medical facility is charged with doing the testing, and if they're not offering rapid testing, well, then a citation would go to the EMS service. And that's been questioned, and OSHA rethought that. And in 2017, they published the statement that they would also be looking at the full cooperation of all the entities involved in processing and controlling testing. So let's talk about rapid testing post-exposure. And clearly, if the source patient is negative by rapid testing, no further testing of the exposed healthcare worker is needed or recommended. With regard to rapid testing, as I mentioned, the first clear statement on this was published by CDC in their post-exposure guidelines in 2001. And it says clearly, second line, hospitals, clinics, and other sites that manage exposed healthcare personnel should consult their laboratories regarding the most appropriate tests to use to expedite getting these results. Clearly, that is rapid testing. Where does enforcement of CDC guidelines come from? And they come from the General Duty Clause of the 1970 OSH Act. The General Duty Clause, Section 5, Part A, says that employers must protect employees from recognized hazards that are causing or likely to cause death or serious physical harm. Here's the key part, that they can issue citations and fine even when there are no regulations that have been violated. So this is a really good catch-all clause, and this is what OSHA is using to enforce the CDC post-exposure guidelines. The CDC is now recommending that everyone between the ages of 13 and 64 get tested for HIV at least one time as part of routine health care. For those at higher risk, the CDC recommends they're getting tested annually. And the key to risk, remember, is dose-related. How much virus is circulating in that patient's blood? So if someone were to test positive by rapid testing, then a second test needs to be performed called viral load. This will tell us how much virus is or is not present in that individual's blood. When done in-house, this takes between 2 and 3 hours. If blood had to be sent out, you could not get results possibly for 5 days. So viral load, dealing with HIV, we are looking specifically for greater than 1,500 copies of the virus per milliliter of blood. Now, the AIDS cocktail drugs, which have been available for several years now, known as antiretroviral therapy, or ART, these medications block the HIV virus from producing new virus in most patients. So, testing for viral load is key if the source is HIV positive. If that source is positive, Then we would draw a baseline on the employee, test again 6 weeks later, and then 4 months after the date of the exposure, we would do the last test using rapid testing. So this has been compressed, and the latest published time frame, as you can see, was in 2013. Now, if the exposure meets the criteria for offering PEP drugs, CDC published that we now have 72 hours to offer these drugs if it's appropriate to do so. That gives us ample time to get an exposed employee into someone who can do proper counseling about the pros as well as the cons of prescribing these medications. Now, if the healthcare worker exposure is outside of an occupational health clinic, and your people are going to be followed up by emergency physicians or others who are not experts in the treatment of HIV infection or the use of antiviral medications, then the CDC wants that treating physician to contact the PEP hotline to get a second opinion as to whether or not these drugs are warranted based on the type of exposure that occurred. They are never automatic. So we've heard about ART, the triple drug cocktail. And as back as early as 2012, we had data clearly showing that individuals who were taking these medications, that by 48 weeks of drug treatment, they had no circulating virus, meaning no dose to transmit the disease. So 96% could no longer transmit the disease. That was back in 2011, 2012. And now we know that persons who are HIV infected from time of diagnosis to end of life is 50 years. You're seeing advertised on television the drug Dovato. This is a 2-drug combination, and this is targeted specifically to newly diagnosed HIV-infected persons, so those who have had no prior treatment for HIV. And that Tarve is also a combination drug given 1 pill a day, and it lowers viral load to being undetectable within 8 to 24 weeks. And financial support for these medications is available. So, available. How is it available? Money for drugs, money for medical care. Well, the largest government program to fund all of this is the Ryan White Care Act. Your notification law was added on to the back of this law, which is mainly a funding document mechanism for HIV/AIDS. So there is mandatory reporting of HIV infection that went into effect in 2002. And the goal of all of this is to do more testing so we can get people started early on treatment, identify areas where HIV infection is increasing to get more programs up and running, and to focus on fiscal and care resources, planning to expand, modify the Ryan White Care Act. Now, the Ryan White Care Act is not the only funding program available. There are others. So it's safe to say that treatment, medications are available to everyone in this country, whether or not they have the ability to pay for it. That brings us to the end of this podcast session. And if you have any additional questions or answers, please feel free to contact me by phone or by email. Remember this, in today's world, just because someone is HIV positive or has a diagnosis of AIDS does not mean they pose a risk to you for disease transmission. Thank you. Take care and work safe.